Welcome to the Auburn Medical Group YouTube live stream, the entertaining medical live stream where viewers can ask real-time questions of real medical doctors. And here are our hosts, Dr. Mark Vaughn and Dr. Gwen Vaughn.
Welcome to YouTube. On behalf of YouTube, I'd like to welcome you. Take it upon myself.
This is the YouTube.
Sorry.
Oh my goodness.
Did you feel it?
But
Did I spit? Sorry. That's
we are the
full
Auburn
immersion
Medical
television.
Group
Yeah.
YouTube channel.
Talking today about what's family medicine?
What is family
What?
medicine?
What is it?
Oh,
Family
great
medicine.
question.
And ignoring the fact that we just did the same subject 2 years ago.
We don't remember, so how could you?
And we will jump right into the subject, family medicine, and then come back and look at comments like Rusty B, who's saying hi. But no, we're not going to do that. Here we go. Sorry about that. Is the music still playing? If the music's still playing, I apologize. But there we go, Rusty B. And Bianca. Okay, stop me. We need to get to the subject.
All right. Hey, we need to talk about that.
We need to talk. We need to talk about family.
What is family medicine?
What is family medicine?
It's when a family
I feel like this is a
does medicine. It's like what we do.
When your kid is sick, you take care of them.
That's family.
You give them
medicine.
Tylenol. That's family medicine.
Yeah. So family medicine is
the show done? Can we go to the comments?
One of the recognized, accredited, what are they called? American
Board of Medical Specialties,
That's what it is,
ABMS.
ABMS. So it is one of the...
See, I know something.
Hey, glad I keep you around. So it is one of the accredited boards out there for medicine. And that is what I'm
Wait, you're what?
board certified in.
Oh yeah,
So-
you're real.
I'm real.
He's actually
family
ABMS
medicine.
certified
I
in
am.
family medicine. I, on the other hand, not board certified in family medicine or anything
you
now, and I don't care.
All right.
So he chose family medicine.
I did.
Family medicine chose me.
Wow. That's deep somewhere.
It kind of makes sense, though, doesn't it?
Yeah.
If you think about it. Anyway, so contrasting it against what it's not, other specialties.
Yeah.
Although it does a lot of what other specialties have. But the reason I say what it's not is because he pointed out the ABMS, American Board of Medical Specialties. They have
A list.
certain, it's a real list of things like internal medicine and general surgery and
ENT, gynecology.
Those obstetrics, gynecology, pediatrics, internal medicine. So those are specialties recognized by the ABMS. There are other specialties that are made up and make up their own boards,
their own board.
Boxing medicine and
medicine.
what are some others? Complementary medicine.
Yeah. I read one that was like a functional medicine.
Functional
thing.
medicine. There's people that go out and they'll make up their own and they'll make their
Recognized
certificates.
ABFM. Yeah.
But
You'll see the
ABMS,
certificates in their office even.
they have a website, probably abms.org, I would think, but maybe not. American Board of Medical Specialties. And you'll see emergency medicine, you'll see family medicine. I did a residency in emergency medicine, was board certified in it for 20 years,
Yeah.
I guess.
About that long, huh? Yeah, because it was your second.
And then stopped taking the exams. Can't do family medicine. At least we haven't really looked into it super hard, but our thought is you have to do a residency, which means,
To do that, you would have to go
back to taking a digit off of your salary.
Yes. And 80-hour work weeks. And
Yes.
working twice as long for
Being
a tenth of the pay.
being a student that other
Oh,
people send to do their scout work. No, I'm not interested in that in the least. So no, I'll just be not certified and keep doing family medicine.
We do well here. We do well. So family medicine, some people say, oh, you're a family doctor. What does that mean? What do you do? And the long and short of it is a little of everything.
Yeah, let me show you the slide.
Hey, we got a slide on that. Check it out.
There it is. That's
there it is.
You can talk over. See over.
If I
Get
can
it and talk
see
over
that, man.
You can read it over here.
Yeah. Oh, there we go. All right. So there's family medicine.
There it
we
is.
are comprehensive. So it is kind of cool knowing that anything that comes through that door I know what to do, and part of that is sending to the ER for some things, or part of getting them into a doctor who knows what the proper.
Yeah, you say that, sometimes, but that takes knowledge too.
That's true. To know what is appropriate.
What's the thing I can look at and
say,
this could look a lot like something that should go straight to the emergency department, but this certain little bit of feature about it makes it so we don't have to.
Yeah, right. Or the other way around. Boy, this looks really normal, but there's one thing there that makes it that this could be something really scary. So, yeah.
And we have that happen with patients coming in, and a lot of times they'll be able to triage themselves correctly.
Sometimes they don't.
I need to go to the emergency department for this substernal chest pain radiating to my left. Yeah, go ahead, go to the emergency department.
Yeah.
Sometimes they wouldn't have to for the exact same chief complaint. We could do an EKG here and go deep into the history behind it and do an examination to determine. We actually don't have to do what they do in the emergency department for these symptoms for this person.
Yeah. So that is so we are comprehensive. Like I said, anything that comes through the door, and sometimes that is referring to somebody who specializes in that area of medicine. Yeah. We do. Essentially a little of everything. So if you come in, we'll take care of your mental health. We'll take care of your infection. We'll take care of your annual preventive care, which I think is another thing on that list. So it is comprehensive. A family doctor is your primary care doctor. We are the ones that are kind of the your entrance into the medical establishment. So so you want us on your side. We want to be on your side.
Yes, absolutely.
Because a good family doctor can get you into the appropriate doctor, but also keep you from going to unnecessary doctors.
Yes, yeah. Like sometimes when we have patients call and say, "Oh, give me a referral to the orthopedist or the dermatologist or even eye doctor." Sometimes,
when some of that we can do here.
We can do that.
You need a little thing burnt off your face. You don't need to go to a dermatologist. We can do that at our office.
Yeah, and with some of the specialties, they actually prefer for us to keep you out of their office so they can take care of different type stuff. Like the orthopedist wants to take care of the things that need to be operated on, things that don't need to. They prefer for us to just take care of it for them.
Right. Yeah. Let's see here. So that's procedures. That's the next thing on the list, which we didn't talk about a little, but I touched on it. So dermatologic procedures, doing biopsies, cryotherapy. Those are kind of the derm ones we do. The big
sometimes
ones.
Excisions.
Yeah, excisions.
Injections, orthopedic injections.
INDs, incision and drainage of like an abscess or something like that. Lots of injections. We do those procedures here, which is kind of cool.
Some pain injections, even like the greater occipital nerve for the
Actually, I need to talk to you about that. I got a patient that wants that done. That fits the criteria.
We do that.
Anyways. Let's see, what else? Referrals. Yeah, so like I said, appropriate referrals. We will get you in. We one of the biggest things about family medicine is knowing your limitations. So
yes,
while we are kind of jacks of all trades, we have our limitations. We are not experts in every field. I need a cardiologist for that really critical patient who needs a further test, like a stress test or something. So we can do those referrals. We can get people in. Prevention. I touched on this, but those annual wellness exams for if you're Medicare or a physical, if you're younger than that, those are important. Getting appropriate labs, not every lab out there. We follow the recommendations of the USPSTF, the United States Preventive Services Task Force, which puts out recommendations on appropriate testing without it being excessive. So we don't test for everything in the book because there's not really a need to.
Actually, there's reasons not to.
And there are actually reasons not to.
We have other videos.
Not only financial reasons, but you may find something that means nothing.
But you don't know that until you do all the follow-up.
Right, which then goes, can have all sorts of things.
In the first place,
So we can discuss that with you. Have we have good insight into all of that. So it is worth a discussion with your family medicine doctor.
What you were saying about the appropriate referrals, that's kind of the care coordinator thing. Also, I came across this thing. I haven't even told you about it yet. It was a PharmD. which is a person with a doctorate in pharmacology or a pharmacist, but they had a special designation within the state where they're able to actually prescribe medicines.
Oh, really?
Now, they can't diagnose, but once the diagnosis is made by a medical doctor, they can prescribe.
Oh, interesting.
And there's not that many of them in the state. But this one spoke to us and was talking about a program where they would, for cash, help patients look at their medication list and help them to get less expensive alternatives for their treatment. And also
For cash.
look for problems with interactions. And so what I thought of was,
Cash.
we see that, yeah, for cash. We see in our office quite often patients coming from specialists, or maybe it's a new patient, we will see that they're on medicines that have horrible interactions with anticholinergic activity, especially a problem for our elderly patients. We will see very expensive medicines prescribed by a specialist who seems to not have any concept of what they're asking their patient to really. You just hand out a prescription for something that's $800 a month and like it's nothing.
Oh, man.
So care coordination, a good family practice doctor will take these things into it. And it's very much what family practice, I mean, this is what they preach at family medicine residency is don't, use medicines that are inappropriate for patients because they can't fill them because they're way too expensive or because they have interactions. Seeing all the medicines that are put on by the specialists and looking at the whole bunch and paring it down to an appropriate selection of medicines. When you ask a person, you take this pill twice a day, every day, 14 times a month, 14 times a week, 60 times a month, 700 times a year. That's what they're asking that patient to do when they hand that to them.
Right.
It's not a little thing.
Yeah.
And it's also not a little thing when you think they're taking it or they should be taking it and they don't. So care coordination is a big deal.
Yeah, absolutely.
Yeah.
When patients come back from specialists, they can be prescribed medications, and those specialists are wonderful at what they do, but sometimes they get a little focused on their specialty and don't have the don't look at side effects or interactions with other medications, and it can be helpful to have your family medicine doctors double check that and review that.
With a comprehensive care like we offer.
Yeah.
Now, you'll notice a lot of people who fill the role of primary care will throw that out as something being a reason to pay more money than the insurance already reimburses. This would be like concierge care.
Ah, yes.
Or like this pharmacist I was talking about. Those are out there. We'll get back to why you don't have to pay extra money to get that kind of care in a moment. Although if you want to call somebody in the middle of the night and have them come to your house, you pay up front for that. We're not that. We don't care that much. Okay.
We care.
Family medicine. There's a need for it.
Yeah, actually, family doctors are very underrepresented, unfortunately.
And unfortunately, it's going the wrong direction, too.
Yeah. With the pay for specialties, which we can talk a little bit more about, family medicine is not one of the higher reimbursed specialties. It's actually it's on the bottom.
So the total amount of money spent on healthcare, how much of it goes to family practice? Isn't it about 5%?
It's pretty low. Yeah.
Even though supposedly everybody has somebody filling that primary care role.
Doing the work.
It's like 5% of what's spent on healthcare.
Where was I going with this? Yeah, because of that, because it's not one of those lower paid specialties, there's not a lot of incentive for students coming out of medical school with huge debt to go into this specialty to take 10 years or more.
The money is not there to get people to come to it. They will go.
Yeah, you've got to
get their $500,000 a year in orthopedics or GI or something else, cardiology, rather than go into family medicine.
Yeah, so unfortunately, and this is the undersupply of family medicine is really felt in rural areas. That's really where we have the issue. Not having doctors. So in the middle of New York City or LA, you're not going to run into this as much, even though there are a lot of people and there may be a little bit there. We're talking about rural Kansas, the middle of nowhere, where they've got to drive 2 hours to see their primary care doctor. They are out there. So
that is the case in some places. Yeah. So we talk about undersupplied. No motivation. And then that's where the role of care extenders come in, which maybe I shouldn't use that term, but we're talking about family
PAs.
nurse practitioners, PAs,
practitioners, yeah.
who are able to practice medicine. They're licensed in their states, and they work under the supervision of a medical doctor, like us, in our office. In fact, today, this afternoon even, while I was preparing the show, I was told, hey, so-and-so has a patient with something on their eye, don't know what it is, like you to take a look at. So I go in there and take a look and say, yeah, we should probably get that biopsied. And
Perfect.
yeah,
Yeah.
by a specialist.
we
referred out.
Not in a place where we were.
Yeah, it was not one I'd be comfortable doing myself. So if it was in a slightly different part of the body, we'd do it. But or if it was smaller.
He knew his limitations. Like I
If it
said.
was smaller, we'd take care of it. But no, if it's that big and it's on an eyelid, nah.
Oh, an eyelid.
No. Yeah, right. So you want the next slide, don't you?
Yeah. Yeah. What else are we talking about? Family medicine.
Let's anticipate what the next slide will say. Oh, comprehensive care for individuals versus for populations.
What does that mean?
So this sort of comprehensive, everything's covered care, looking at all the drug interactions, taking away medicines prescribed by a specialist because they don't know the whole picture and what the other specialists are doing. That kind of level of care and making sure you get all of the recommended testing every year for you specifically that's recommended for your situation. That kind of comprehensive care, we don't have what it takes manpower-wise
It takes time.
to do it for the whole country.
Yeah.
There's just not enough doctors and physician extenders to do it for everybody at the level we're talking.
To do it well. Yeah.
Yeah, what we're saying here is
Yeah,
kind of
'cause-
the standard.
Because you need to sit down. We're talking reviewing medications, reviewing past
Yeah.
medical history, appropriate tests, making sure that we're up to date on everything.
This is in addition to taking care of whatever the patient says, hey, can you check this? Hey, I have a question
way.
about this. Oh, by the way, as
Yeah.
your hand's reaching for the doorknob to get to the next patient.
Yeah.
To take care of all that, there's not enough to go around. So
Yeah.
what has to happen?
So
of that.
it's one of two things. So you either sacrifice that a little bit and see more patients to get people through the door and try to get to extend your care to more people, or you limit your access to be able to give those that you are seeing the comprehensive care they do.
There's no end to the frustration for those people who think they're doing both, who think they can just
see
serve
50
the
patients
whole
a day.
community. And
You can't do all this in a 15-minute visit.
yeah, there's different levels of pay with different insurances. There's the Medicaid or Medi-Cal, different states, and the way that's paid for is through subsidies that come through these federally qualified healthcare facilities, or
FQHC.
or FQHC. You used to work at one.
I did.
We're not FQHC, so we're not getting that money. We're getting it through the insurances and through the Independent Physician Association and the Accountable Care Organization. So we do have a way outside of the insurances that help us to be able to do primary care, but not to the point of being able to take the lower paying insurances, and we wouldn't be able to give the kind of care we do. So we choose what our mission is. Our mission is to give that level of care just short of concierge. Hey, here's my cell phone number. Call me in the middle of the night and I'll come to your house. No,
Yeah.
We're at the level of we have office hours and we will take care of everything. We will get you in,
We'll do it. Yeah.
make sure everything gets done and comprehensively, and use an emergency department on the weekends. Sorry.
If it's appropriate.
So that's the level where we come in, and we're very happy with that. It actually provides for a very nice lifestyle for us. We are on call, but we don't have to come in. We don't have to go somewhere when we get called in the middle of the night or on the weekend. But we do provide everything through our office to make sure people get taken care of. We don't leave them hanging.
Yeah. Yeah. And it works well. I think our patients
We don't have ridiculous
enjoy it.
wait times.
We don't. We're able to spend that time. We do lengthen those visits to allow that time for our patients.
We take care of a lot.
And we
Should we jump into comments and questions?
absolutely.
Okay, let's see what the chat has for us. Okay, we have, who's this? Bianca. It's past midnight here. Oh, where is she again? She's in the UK.
Okay, yeah.
So happy Valentine's Day. Oh,
It's
Valentine's
already
Day. For,
Valentine's Day.
she's
Today is
making
the
a grimacing
13th,
face.
which is
Okay.
my wife's birthday.
Oh, happy birthday, Shelley. We also have Lindsay Antoine here. Woo, yay. Lindsay saying, I needed you guys a few nights ago when my dog stabbed his claw through my forearm. You know, the dog would probably suffer very little from that, so I don't know that we'd be able to help the dog.
Yeah. Dog's probably fine.
Moving on. And then Bianca, I think I'm getting the same as RGP, general practitioner. Bianca, I love our NHS for this. Yeah, NHS probably focuses on getting primary care.
Yeah, they probably have a big emphasis.
Because it's a centrally run entity with the mission of getting costs down and good general care.
Right.
Rather than focusing on giving everybody the $100,000 treatment if they happen to get that rare illness.
Yeah.
Like our system seems to focus on too much. And then, we have a new commenter, Koro, giving us a thumbs up and giving us emojis. And then Lindsay, thanks for the love. I'm really feeling it.
Nice.
She caught that. Sorry, Lindsay. We're so mean to her.
Yep.
So
let me make a quick comment about
our uncaring attitude toward Lindsay's arm.
I was going to talk about specialists versus family medicine and why I have a bone to pick with loan repayment. All right.
Oh, this is good.
First of all, I didn't get my loan repayment. I signed on for 2 years in FQHC. We just talked about that. Federally Qualified Health Clinic promised that I would get this loan repayment. Didn't happen. Apparently, so that's one thing that you're not following through on things. And I'm sure I'm not the only one. But currently, the program has changed so much since I've been in school that it's now like a 10-year program. So you've just got to make these minimal payments for 10 years and work at a quote-unquote FQHC or a nonprofit or something like that. Here's the thing. As family practice doctors, we go to school and then we start to, in your residency, you can become qualified for these. We have a short residency, 3 years. So we only have 3 years and then we've got to do 7 years beyond that in one of these centers. Now, if you specialize, your specialty is longer than that. So you can use your whole specialized residency, which could be up to 9 years.
With fellowship.
And get your loan repayment. And then when you come out, you're a specialist making a specialist's income.
Wow.
It's a problem. So there needs to be some sort of loan repayment reform to better subsidize, whatever we want to call it. That's a bad word. I know some people don't like that word. But help out primary care physicians, pediatricians, family practice doctors, internists doing primary care to give them an incentive to actually do primary care. There you go. My rant's done.
No, that's totally appropriate. And in fact, that's a conversation that we hear quite a bit at boards that I serve on. We're talking about how do we get primary care.
Like here, we would love to have another doctor here.
It's hard.
But we're a small private
We've been recruiting for how much?
Yeah.
Over a year.
Yeah, and we can't
We've talked to some people.
A huge amount of loan repayment.
But we can't keep up with the good big guys.
Right, yeah.
Who do subsidize through their specialists.
Yep.
Because they're multi-specialty groups, so the cardiologists and the orthopods throw in some of theirs so the group can pay what it takes to get a primary care doctor to be a part of their big, gigantic group. And then there's us, the two of us.
Needless to say, we're aggravated.
So we're working on it, and we do hope to have somebody join us too.
Yeah. So.
Yeah.
There you go.
Well, thank you, Dr. Gwain, for
my rant.
That was very well. You found your voice. Okay. And then somebody saying good night, 555 Joan, I guess. Is that
what?
It's just saying good night.
I thought you were telling I should call a number.
No.
High five.
High five.
It's like,
Lindsay again. Okay, Lindsay says, imagine if higher education was actually affordable. Yes.
That's a crazy thought.
Instead of paying back loans, why don't we make it cost less in the first place so we're not paying backwards, we're going forward with the new. Yeah, I agree. Consider an investment in the country so people could pursue doctorates and we wouldn't have such a shortage of medical. Absolutely. I'm all for making education affordable when somebody's doing it instead of after the fact addressing loans that doesn't do anything to solve the problem.
Yeah.
You still have it costing too much for, somebody who doesn't come from a well-to-do family. How are they going to have a chance of?
Yeah.
I
Didn't have any of my medical school paid for. Had to take out loans for all 4 years.
Yeah.
And didn't get that loan repayment, so I had to pay it all back myself.
Yeah.
So set you behind financially a little bit.
Look forward.
Even though I'm a rich doctor.
Yeah. Well, now you are. You weren't for a while, though. Okay. So thank you for your comments and questions, and thank you for sharing this with friends who are interested in the subject. And I guess you have to throw out. I'm spitting again. I'm sorry. Did I get that on you? Let me rub it. Let me wipe it off.
Over this way. At least you're facing that way and then shooting it this way.
Anything you wanted to get out there?
Don't look at me. I'm scared.
Anything you wanted to get out there?
Not really.
Now that you don't have a blog?
I won't be here next week.
Oh, next week when we talk about...
What are you talking about next week?
We're going to talk about the only thing that's actually been found with rigorous study to be a true aphrodisiac.
Ooh, that sounds exciting. Man, I'm going to miss out on that.
Kisspeptin. Have you heard of it?
I have not.
So I'm going to look into it. I have just heard initially about it, and as far as I know, it's just research at this point. But interesting. There will be people who want to know about it, and since it's new, maybe we should write a song about it.
I won't be
No song or rap this week.
Sorry.
Do you want to try the family medicine rap?
Oh, no, I do not.
Well, only if we really had overwhelming requests. Oh, Koro...
in the style of...
It's Beastie Boys, wasn't it?
Beastie Boys, yeah.
Koro wants us to know that you two are so great, you're funny, and you're very smart.
Thank you.
How do you know we're very smart?
We were just talking about family medicine.
Wouldn't you have to be, like...
We look like it.
Smarter than the person that you're judging is smart?
What?
Because we could be just talking out of our ears...
out of our...
And you know, unless you know the subject better, you wouldn't know.
Talking out of our place you use Astelin. Wait, that'd be our nose.
Okay. The patient comes to the doctor
I do, yeah.
who's been prescribed a nose spray called Astelin. And the doctor asks him how he's using it, and he goes into the description of how he
Why isn't this working,
administers the medicine. And the patient looks really confused after having done it for a week, and the doctor follows up. And so he asks the doctor, well, if you were supposed to spray Astelin in your nose, wouldn't it have been called Nose-Telin?
Yeah. Yeah, pretty much.
Now, is it a dead house, or is it...
What's the quote from Scrubs? That's analgesic, not analgesic. Sir, the medicine goes in your mouth.
It's an analgesic. It takes care of your pain. Oh, wait. Okay, Koro has a question. There's only one question I have. You talk about such serious subjects, but you've got a dummy between the two of you, right in the back against the wall.
Yeah.
How are we supposed to...
That's why we look so smart.
Okay, first of all, we prefer the term anatomic model
dummy,
or mannequin
so
rather than dummy.
Denigrating.
This actually is an anatomic model that you can take the organs out and look at them and talk about them. We do sometimes take different ones out. And, now I have to get the...
oh, look what you did.
Oh, what? It doesn't have a trochlear.
That's true.
Or a, what's it called?
Abducens? That's the nerve.
No, it has the abducens, but not lateral rectus. What's the one called? Is it trochlear?
Yeah.
I'm sorry. It's very embarrassing for a doctor to not remember basic anatomy.
Oh, I don't know how it wants to go in. That's good enough.
Anyway.
Hopefully that eye doesn't fall out.
So
thanks for joining us.
So thanks for joining us. But we consider it to be a very serious educational tool that we sometimes use on the show. So let's wrap that up, and thank you for watching. Until next time, this is, there.
Are you talking about, I'm Dr. Wayne Vaughn.
And Dr. Mark Vaughn and Lindsay Antwine, who helps bring the show to you, as you can learn about over in front of Gwen here in a little bit. Talks about Patreon. That's how you get your name on the screen. Along with all these great folks.
See ya.
Stay in good health.
Doctors, thank you for another informative session. Auburn Medical Group is located in Auburn, California, USA. Thank you for participating. Please tell a friend and join us again next week.